Okay. Good afternoon, everyone. Uh, Welcome to Innovate 2022's series of free expert lectures. Kicking it off is Dr. Ishwara Bhatt, a professor of dermatology at St. John's Medical College Hospital and a member of the Nodal Center of Medical Education, National Medical Council, speaking to us about acute skin failure, which coincidentally, or rather not coincidentally, very deliberately, is the charitable cause for which the proceeds of Innovate 2022 are dedicated. So over to you.
Good afternoon, and dear students, and I'm very happy to be with all of you here on what I realized was a very noble cause, which has been initiated by our students, Innovate 2022. And I will share with you over the next 30 minutes what you should know. All of you are now, many of you are going to be primary care physicians. Some of you may already be primary care physicians. And what you should do and what you should know as a primary care physician when you see the concept of acute skin failure. So without much ado, I shall cover this. This acute skin failure is a very vast topic which has so many aspects. So I need to cover it over the next 30 minutes or so. So I'll put it as succinctly as possible. So we shall deal with what actually happens in acute skin failure. What is the concept? What is lost? What is the pathophysiology? What are the various causes of it? What complications can arise and how can you manage? So if you look at the functions of the skin, the most important function of the skin of all is the barrier function. It has a lot of other functions. There is temperature control, fluid and electrolyte hemostasis, and vitamin D manufacturing also happens. But the one that tops it all is the barrier function. That is the most important function. And that is the one that goes for a toss when you have acute skin failure. So what are the types of skin barriers? It's not just a physical barrier. So we think of skin as only a physical barrier from the surroundings, from the environment, but it is not so. See, there is a physical barrier which consists of the stratum corneum and the nucleated epidermis, but it's a little more complex. There is also a chemical or a biochemical barrier in the form of lipids and organic acids. The skin is very active in producing an antimicrobial defense system in the form of various enzymes and antimicrobial peptides. And also there's an immune system. There's a very active immune system. People don't really associate an active immune system in the skin, but it is not true. There are a host of immune cells like lymphocytes, neutrophils, monocytes, and Langerhans cells, which play an active role and provide the first line of defense against organisms. So this is the skin barrier is more than a physical barrier. It's also chemical, it's also antimicrobial, and as an immune barrier. Now, the permeability barrier is the most important function of the skin because it forms a barrier between the organism and the environment. Organism, I mean the patient in this case. So there are two primary functions of this permeability barrier. Very simply put, you can remember it as it prevents what is outside from getting in and prevents what is inside from going out. So what does it protect from inside to outside? That is, prevents against transepidermal water loss. TEWL stands for transepidermal water loss. So it protects against excessive transepidermal water loss. And the second thing it does is it prevents penetration of harmful compounds into the body. So outside to inside barrier. So this is the most important barrier that is lost when you have acute skin failure. Its efficiency depends on a lot of factors. For example, very young children and very old people, the skin barrier is a little less robust than compared to, for example, a middle-aged man. Environmental changes, for example, extremes of temperature can change this. But the most important thing that you need to have a robust permeability barrier is the continuity of the skin. So you have to have continuity of the skin. Without that, this permeability is lost. So this is an important concept. So remember, when you're thinking of acute skin failure, I always teach when you're undergraduates supposed to do this. When there is acute skin failure, what is inside can go out, what is outside can come in. It's very simply put. So what's outside can come in is organisms and infections. What's inside can go out, fluids, electrolytes, proteins, and other things. So this is what you have to remember. So that is what you have to remember when you're talking about acute skin failure. So this is the classical brick and mortar model of the skin. It's not just a simple keratinocytes attached to each other. The keratinocytes are there, all right. They form the bricks, but they are cemented together with intercellular lipids, which form the mortar. You have the epidermal cells and the basal cells. So they all have to be cohesively working together to have that permeability barrier, which we just spoke about. Can it be assessed? Yes, it can be. One of the best measurements of assess barrier function is the transepidermal water loss measurement. In a normal human being, the normal transepidermal water loss is about 0.5 milligram per centimeter square per hour. So, in simply put, in an adult male with a uh, body surface area of about 2 square meters, the transepidermal water loss is about 200 to 300 ml per day. This is the normal loss that takes place in a person who's normal, 200 to 300 ml of water loss. So that happens by evaporation, sweating, and other things. This is what goes up drastically when you have acute skin failure. So in acute skin failure, there is state of total dysfunction of the skin resulting from different dermatological conditions. It represents an emergency, which is why we are talking about it today, needs a multidisciplinary and intensive care approach. So to define it, there's a complicated definition, but I've highlighted those in the green color. There is loss of normal temperature control and failure to prevent percutaneous loss of fluid, electrolytes, and proteins with resultant imbalance and mechanical barrier. So three things are suffer. One is temperature control, percutaneous loss of fluid, electrolytes, and proteins, and the failure of the mechanical barrier to prevent penetration of foreign materials. So what could be the causes of acute skin failure? There are so many causes. Dr. Soumya later will be talking about some of them in the form of immunobullous disorders. That is one of the causes. But if you look at the causes, you're looking at conditions where skin is lost, like Steven-Johnson syndrome, toxic epidermal necrolysis, other immunobullous diseases like pemphigus vulgaris, mechanobullous disorders, which is seen in the neonates like called E. bullosa. You have pustular psoriasis, and then you have some infections in children like Staphylococcus scalded skin syndrome. In this case, the skin itself is lost. So there is loss of skin. It is just like a patient with burns, for example. Now we are talking about dermatological conditions. We are not talking about burns. Burns patients also represent a patient with acute skin failure, but that is due to a traumatic process. The second group of conditions, these are examples. The one on the left you see is a young baby who's got Staphylococcus scalded skin syndrome, and the one on the right is a patient with pemphigus with skin loss. Again, patients with extensive loss of skin. And you can see here on the right side, a patient with toxic epidermal necrolysis with large sheets of skin peeling off. The second group of disorders where you have acute skin failure are those which can present with what we call as erythroderma. Now, as we teach our undergraduates, the definition of erythroderma is persistent erythema and scaling involving more than 90% body surface area. Now, that is a morphological term. The etiology could be a host of conditions. It could be disseminated eczema or dermatitis. It could be psoriasis. It could be dermatitis or erythroderma secondary to drug rash, certain disorders of keratinization, cutaneous T-cell lymphoma, GVHD, and so on and so forth. So in this, the skin is not actually lost, but there is inflammation of the skin, and that inflammation compromises on the mechanical barrier which we talked about before. So because of the inflammation, there is loss of barrier function. So in the first group of conditions, immunobullous, the skin is actually lost. Here, the skin is not lost, but because it is inflamed, there is loss of barrier function. So this is the second group of disorders where acute skin failure can happen. So some examples here, you have a patient on the left who's got erythroderma secondary to psoriasis. So you can see that the skin is intact, but there's so much of inflammation that the barrier function can be lost. And on the right, you have a child with ichthyosis. Again, a patient who's presents erythroderma and can have loss of skin barrier. So two group of disorders, remember that. One is you can have patients with skin failure. Second, you can have patients who have skin, but it's inflamed or in erythroderma, which presents in acute skin failure. Now, what happens? What happens when you have acute skin failure? The first thing that these are the main things that suffer when you have acute skin failure. You have a state of altered hemodynamics. altered thermoregulation, metabolic abnormalities, fluid and electrolyte imbalance, loss of nutrients, organ dysfunction, and infection and sepsis. One or more of these ultimately result in circulatory collapse and the patient goes into shock. So we'll talk about each of these a little bit in detail. So what happens in altered hemodynamics? Because of the persistent skin inflammation, there is marked vasodilation, increased cutaneous flow with erythema and edema. So this results in an increased cardiac output, and therefore the patient ends up with what is called as a high output cardiac failure. This is especially true in those patients who have erythroderma. So patient will have a bounding pulse and they have what is called as high output cardiac failure, because there's so much of vasodilatation that there is increased flow. So the heart is pumping and pumping more blood to maintain the circulation. So that results in a high output cardiac failure. Why have I put this picture here? This frog is actually, why I put it is, frogs are known to be what are called as poikilothermic. If anybody knows what poikilothermic is basically an organism which takes the temperature of its surroundings. So I told you the second thing that goes for that suffers when you have acute skin failure is loss of thermoregulation. Now, normal thermoregulation is that if when the temperature rises above normal, there's a thermoregulation center in the brain and the hypothalamus, which triggers sweat glands to secrete sweat and also causes vasodilatation. So the body cools down. And conversely, if the temperature falls below normal, the reverse happens. And so you have maintenance of the body temperature between 36 to 38 degrees, core body temperature. Now, in those with acute skin failure, this is lost. They're neither able to maintain normal temperature when the temperature drops below or goes above. So they take the temperature of the surroundings and they become what is called as poikilothermic. So that's one thing that happens in patients with acute skin failure. And the way to detect it is actually to take a rectal temperature. But remember that in a very hot environment, for example, if the patient is in Rajasthan in the middle of summer, he may become hyperthermic. Whereas if he's in Jammu Kashmir in the middle of winter, he may become hypothermic. So it's important to remember the temperature regulation. So it's important to maintain an ambient temperature when taking care of these patients. So that's the take home from this. So you have a patient who's got altered thermodynamics. And the other thing that happens in psoriasis is that the sweat glands get occluded and therefore hyperthermia can happen. Now, one important thing is suddenly if there's a patient who's hyperthermic and suddenly becomes hypothermic, remember that it could be a premonitory sign of sepsis. So it's important to look for this when you're looking at these patients. The third thing, you have metabolic changes. Most important among them is hyperglycemia. Hyperglycemia is known to cause several causes for it, but hyperglycemia is known to happen with glycosuria, and that further contributes to the morbidity in this patient. So important to look for hyperglycemia in patients who have acute skin failure, especially erythroderma. Next thing that suffers is fluid and electrolyte imbalance. We talked about this before. What is inside can go out. So normal body loss, water loss to the skin is about, I told you, 200 to 400 ml per day. Now, when a person who's got even 50% of the body surface area with erythroderma, it can drastically jump up to about 10 times that. So he might lose 3 to 4 liters per day. So because of that, what happens? Intravascular volume drops. The patient has hyperosmolar urine, and all the electrolytes, imbalance takes place. So in a patient who's got acute skin failure, one of the things to look out for is loss of intravascular volume, hypovolemia, and for electrolyte imbalances. So that is why you'll see us asking for those investigations in a patient who's got acute skin failure. So you have to look out for that in these patients. They might go in for prerenal azotemia. In addition, in patients who have skin loss like the bullous disease, there's extra loss of electrolytes in the blister fluid, and they also go for hypophosphatemia, which aggravates the insulin resistance. One thing, in patients with pustular psoriasis, they are particularly prone for hypocalcemia, which can also be a trigger for pustular psoriasis. So look for electrolyte imbalances in a patient with acute skin failure. Look for loss of fluid. So ask the patient how much urine has he passed. Maintain an input-output chart. Look at his mouth. See if it is dry. Look for features of fluid loss in these patients. Nutrient loss can also happen because if the patient is chronically, many patients will be having erythroderma for a long time. So proteins and ions are lost in the scales. And in the patient who's got diffuse scaling, he may lose up to 30 gram per square meter per day. So along compound that with the loss in the urine, and it may go up to 150 to 200 grams per day. So hypoproteinemia is an issue in these patients. Might need to supplement with high protein diet in many of these patients who have, especially those with chronic erythroderma. Protein deficit takes place just like I spoke about, and therefore the patient goes into a negative nitrogen balance. What happens to the iron and vitamins? There's impaired absorption. See, you have loss, and not only that, many of them have a non-specific inflammation in the gut. So because of that, there is impaired absorption and utilization of iron and vitamin B12. Iron is also lost in the scales. Because of the increased cell turnover, there's an increased need. So the patient may develop what is called as a dimorphic anemia. He's lost iron and is not absorbing B12. So the patient might get a dimorphic picture. He might get both macrocytic and microcytic anemia. So in these patients, one has to look out for that. And if it is found, you have to supplement appropriately. Patient may develop pulmonary complications in the form of aspiration pneumonitis because the patient is very sick, moribund, always lying down. Look for this. Auscultate the patient. Look for cough. If there is cough present, sudden onset fever, then consider the possibility of aspiration pneumonitis. All the more so in those patients who have Stevens-Johnson syndrome, because they'll have a lot of involvement of the larynx and the pharynx. So what happens when they're swallowing, they may not swallow properly and they'll end up with swallowing causing an aspiration, and they get aspiration pneumonitis. Because of the nature of the disease, they may develop ARDS. And the other important thing is, I talked about hypovolemia at that time. So you will see that the patient is hypovolemic, having pre-erythemia. So what happens very often, your tendency is to pump the patient with fluids. Now be careful of that, because what happens, overzealous correction of hypovolemia may result in pulmonary edema. So one has to keep a watch. Input-output chart is a good way to maintain so that we don't overcorrect the hypovolemia and end up with the patient getting pulmonary edema. In addition, one more complication that I have not put up here is many of these patients may be obese. They'll be lying down for days on end, without moving their limbs. So they can develop what is called as deep vein thrombosis. So what happens, suppose a patient is there with erythroderma or acute skin failure, suddenly develops calf pain, or suddenly develops, if the patient gets DVT, and God forbid if the DVT get dislodges, it can become a pulmonary thromboembolism. So encourage the patients to be moving about, or at least moving their limbs to prevent this. In some cases, you might even need to give them a prophylactic heparin to prevent the deep vein thrombosis. So these are some of the systemic complications that happen. What happens to the immune dysfunction? We talked about the skin having an active immune system. In patients with acute skin failure, all the penias can happen: lymphopenia, neutropenia, thrombocytopenia. Whatever neutrophils are there, they do not perform proper chemotaxis and phagocytosis. Serum gamma globulin levels may drop, and there may be CD4 lymphopenia. What happens to the infections? So because of this barrier loss and immune dysfunction, all organisms are able to get in. So there's entry of commensals, endogenous, exogenous organisms, both endogenous and exogenous organisms. Those organisms, the skin has a lot of commensals. Now those commensals in a normal skin will be okay. But when there is loss of barrier function, these commensals can get in and they can cause a systemic infection, and the patient can go into septicemia. Now this very often happens. The commonest cause for mortality in patients with acute skin failure is septicemic shock. Septicemic shock. So what happens, we can do a lot of things, we correct a lot of things. So the importance of this, what is the importance of realizing this, especially when you see a patient with acute skin loss like the ones Dr. Soumya will be talking to you about? It's important to ensure that you maintain barrier nursing. So when you're seeing this patient in the periphery, or when you see it, the first thing to do is, very often they'll have applied a lot of things. Somebody will have told them to even apply cow dung. We've had patients who come with acute skin loss, TN, who applied cow dung on their bodies because, somebody has told them that that's a cure for everything. Or they'll apply some paste. So the least that you can do is maintain barrier nursing, make sure that they minimize the risk of infections both from the environment as well as from other patients. These patients need to be isolated. We should not have 25 people coming into the room every day to see the patient, because the most important thing is to prevent that infection from happening. In addition, you can have reactivation of latent infections like herpes simplex infection, which will all result in septicemia. Peripheral edema happens due to a host of causes because of hypoalbuminemia, cardiac failure, and due to increased capillary leakage. So what happens with all these things that happen? You have altered hemodynamics. We spoke about this, which results in a high output cardiac failure. The patient becomes poikilothermic. You can have hyperglycemia. You can have fluid and electrolyte imbalance, loss of nutrients in the form of hypoproteinemia. Patient can go in for organ dysfunction, respiratory system, GI immune, and infections and sepsis can set in, which all result in circulatory collapse and shock. So in these patients, both the type of shock can happen. One, during the acute phase, because of loss of fluids, he can go into hypovolemic shock. That happens in the initial days, stages of acute skin failure. After some time, he's recovering and the skin is recovering. That's when the second part happens, which is the septic shock, because the infection takes a little time to get into and cause septic shock. So remember that the battle is not won when the patient has made an initial recovery. Very often we think, okay, the patient is recovering. Then secondly, the second week of the rash or the acute skin failure, the second thing, which is the septic shock, can happen. So I won't go too much into the criteria. You can look up that. You all know about this. You must have learned about it in medicine. The criteria keep changing. But one thing just to highlight how to differentiate hypovolemic versus septic shock. I think one of the things that helps is if it's cold, clammy skin, if you touch the skin, if it's cold and clammy, it's more likely to be hypovolemic. Whereas if it is warm and the periphery is warm, it's more likely to be septic. And CNS features take place late in hypovolemic shock, whereas septic shock, the CNS features come up early. So this helps to differentiate the two because it helps in the management. Because if it's hypovolemic, it's predominantly fluid correction, whereas in septic shock, you have to institute antibiotics. So I already spoke about this, deep vein thrombosis and stress ulcers can happen due to chronic disease and anxiety. Management of acute skin failure includes in management of the medical complications and also the primary skin disease. Identify sepsis. There are so many scores there, but this one at the bottom called the QSOFA score is a very useful one for you as a practitioner, because you don't need any investigations. If you see a respiratory rate of more than 22 breaths a minute, systolic blood pressure less than 100, and an altered mental state, you can be pretty sure that this patient has got a quite a very high predictability rate. The patient may be going into sepsis. Those three things, if you see. So there are so many scores available. Look up that. How will you investigate? You have to investigate to establish the cause. So we do a biopsy, immunofluorescence, indirect immunofluorescence. We monitor for medical complications to plan suitable therapy. So all these things, you have clinical parameters, including the pulse, respiratory rate, blood pressure, input-output chart, GCS, chest X-ray, biochemical parameters in the form of glucose, electrolytes, liver function test, renal function test, CBC, and of course microbiology. If you're suspecting sepsis, you do a blood culture, but you can take a swab culture from the skin. Sometimes you have to take a Zang smear to rule out herpes, and serology as needed. So what are the measures? One is it should be a team approach. Counsel the patient and the attenders regarding guarded prognosis, but don't counsel the patient regarding guarded prognosis. Counsel the attenders. This is especially important because you should be counseling them right from day one. Last thing you want is a host of attenders coming and screaming at you when something goes wrong. So from day one, tell them about what is the patient's condition and tell them about the guarded prognosis. Minimize attenders. I spoke about barrier function, barrier nursing. If possible, when possible, they should be lodged in an ICU or a burns ward, or at least in an isolated room. And if you're on rounds, what we do is we make sure that we see that is the first patient on rounds, because we don't want to carry infection from other patients to this patient, and DVT prevention exercises. General measures include maintenance of temperature. I told you patients can become poikilothermic, and ideal temperature is between 30 to 32. Burns cage can be provided, removal of the crusts, IV line, central line as required, and nasogastric tube and catheter as required, if required. Not always, if required, because the chance of infection goes up once you put in a catheter. An easy way to maintain and assess for tissue perfusion is urine output should be this. Thumb rule is if you have a urine output of 50 to 100 ml per hour, then there is adequate tissue perfusion. This is a good thumb rule to remember in all cases. We're talking about hypovolemic shock. So if you're having urine output of 50 to 100 ml per hour, then you're having good tissue perfusion. If you have access to urine osmolality, and osmolality less than 1020 is also okay. Pulse rate of more than 120 suggests a negative fluid balance. Encourage oral fluids, electrolytes as per reports. Again, like I said, urine output should be about 100 ml per hour. So there's a formula to calculate. I won't go into this too much in detail, but to suffice to say that initial 24 hours, you have to give a combination of albumin and normal saline, and supplementation, make sure that you put in the electrolytes later. And depending on the electrolyte reports, you might need to supplement accordingly. Nutrition should be maintained such that they get 30 to 35 kilocalories per kg per day, and protein should be 2 to 3 grams per kg per day with frequent small feeds. Avoid overfeeding because you have the risk of aspiration. Topical emollients in the form of emollients help, and if there is denuded skin, antibiotics and biological dressings can be used. Infection control, hand washing, barrier nursing every time. Swab the patient every 48 hours. Antibiotics used sparingly and used cautiously as per the culture report. And if you find what are the danger signs of sepsis, if the patient is showing altered sensorium, tachycardia, renewed oozing of the skin, or hypothermia, if those four things are seen, then it should ring alarm bells thinking that the patient is going into sepsis. So if you see that, think that sepsis is happening. You might need to give morphine in some patients because of the extreme pain. May not be possible at the primary care setting, but it is used in the secondary or tertiary care referral. So relieve pain. You can give other analgesics. Just give paracetamol. Make sure, but make sure that NSAID you give in case of TEN, make sure it's not one of the drugs that was suspected in the toxic epidermal necrolysis. Anticoagulants, insulin for hyperglycemia, and in SJS you need to do ophthalmic intervention. Disease-specific therapy, you might need to do investigations to confirm diagnosis, like for example, a biopsy. In adverse drug reactions like SJS, stop the implicated drug. That is the most important thing. It should be a multi-team approach. Everybody should be taking care of the patient. You will have to involve the physicians. You might need to involve the ophthalmologists and others, depending on how it is. So to conclude, acute skin failure, host of causes. There are two broad causes. One is the cause where you have actual loss of the skin. Second is those patients who have erythroderma. In these cases, and in all cases, there are many complications can happen. To put it very simply, what is inside can go out, what is outside can come in. So what is inside can go out, fluids can be lost, electrolytes can be lost, temperature can be lost, proteins can be lost, and iron can be lost. What's outside can come in, infections can come in. So if you keep that in mind, you'll remember that these patients. So to manage these patients, try and ascertain a cause. If it is a drug, stop the drug immediately. Make sure that the patient's various imbalance are corrected as far as is possible. Do a Q-SOFA score to see if the patient is going into shock. If the patient is in shock, manage appropriately. And once you have done the primary management of these patients, you might need to refer the patient for further tertiary care referral, depending on the availability and where you are posted. So to conclude, acute skin failure is a dermatological emergency with diverse causes. Multidisciplinary team effort is required. Intensive monitoring is important. And never give up in these patients. The skin may fail, but we should not. Thank you. Any questions, or we are taking at the end?
Thank you so much, sir, for that extremely clinically relevant and to the point lecture. I think we can take a pause for a few questions. If anyone has any questions, just put it in the chat box. Okay, sir. I think if any questions
Okay.
come up later.
All right. I'm sorry I couldn't put it in slide mode, but some problem, some technical issue here.
Thank you so much, sir.
No problem. No problem. Thank you. Welcome.
Next up, continuing with the concepts of acute skin failure, we have Dr. Soumya Kaimal, Associate Professor from the Department of Dermatology in St. John's Medical College Hospital, to further expand on blistering conditions in acute skin failure. Ma'am, over to you. Sir, I think you'll need to stop sharing.
Yes.
Yeah, thank you, Dhwani. And thank you to the organizers of Innovate 2022 for the noble cause that they've chosen this year, and for giving me this opportunity to talk to all of you. I'll just share my slides. Give me a minute. Is it visible, Dhwani?
Yes.
Yes, ma'am.
Okay. So basically, I'm going to be talking to you all about the blistering diseases that featured in Dr. Ishwar's talk. So I'm not going to cover all of them in detail, just a few that I felt were clinically relevant both to the topic as well as for you all as undergraduates. So these are the major diseases that result in acute skin failure as far as blistering is concerned. So I'll obviously not be talking about the scaling disorders like erythroderma and all that. So we'll deal with pemphigus, SJS-TEN, and staphylococcal scalded skin syndrome. So coming to pemphigus, pemphigus, as you all know, is an autoimmune blistering disease, basically caused by anti-desmoglein antibodies. A little bit about the structure of the skin to help you understand the pathogenesis of pemphigus. Basically, the skin consists of several layers that includes the epidermis, dermis, and the subcutaneous fat. And all these layers, for optimal functioning, have to remain attached to each other. So in the epidermal layer, you have again several layers, that is the stratum corneum, granulosum, spinosum, and basal. And to maintain structural integrity, these cells also have to maintain their attachments to each other. So desmogleins are basically components of a structure known as desmosomes. Desmosomes basically link individual keratinocytes to each other. There is also a structure known as hemidesmosomes, and hemidesmosomes link the entire epidermal cell layer to the basement membrane zone. So one is responsible for intercellular attachments and the other is responsible for dermoepidermal attachments. So in normal skin, if your structure is maintained, you have the desmosomes in the intercellular junctions, and you have the hemidesmosomes, that is the pink layer that you can see at the bottom of the first panel, and that is the one that attaches the entire epidermal layer to the dermis. Now in pemphigus vulgaris, that is the middle panel, you can see that the interkeratinocyte junctions are disrupted. So this basically occurs because of the damage caused by the anti-desmoglein antibodies that you get in pemphigus. So when you have anti-desmoglein antibodies, the individual keratinocytes lose their attachments to each other, and a process known as acantholysis sets in. So when you have acantholysis, these cells will separate from each other and it will result in a cleft within the epidermis, which will subsequently fill up with fluid and debris and keratinocytes and acantholytic cells. Now, I'm not going to be dealing with bullous pemphigoid in detail, but just to help you understand the difference, bullous pemphigoid basically is a subepidermal blistering disease. So as you can see, the structure of the epidermis is intact. There is no problem with the cohesion of the individual keratinocytes to each other. But because of the antibodies against the hemidesmosomes in bullous pemphigoid, you have a separation at the basement membrane zone. So the entire thickness of the epidermis gets lifted off from the dermis, and your cleft will be subepidermal. There's also no acantholysis in this disease. So an example of the various levels at which this clefting can occur. In the superficial forms of pemphigus, you have a cleft in the subcorneal layer. So you can see here that the roof of the blister is formed by stratum corneum, whereas the layers below consist of the rest of the epidermal cell layers. So the roof is very fragile. It's just only the stratum corneum that gets lifted off. In pemphigus vulgaris, because of acantholysis, you have a suprabasal cleft. So this basically depends on which desmoglein is targeted by the antibody. So if the desmoglein, we'll come to the types of desmogleins later. And here you can see that the entire thickness of the epidermis, including all the layers from stratum corneum to stratum basale, are all lifted off from the dermis by the formation of a subepidermal cleft. And this is what happens in the entire group of subepidermal blistering diseases, of which bullous pemphigoid is the most important. Now, types of pemphigus, broadly, as far as undergraduates are concerned, you need to remember these two. These are the two important forms, that is vulgaris and foliaceous. But there are also several other subtypes like paraneoplastic, herpetiformis, IgA pemphigus. IgA pemphigus, basically the only difference is that the antibody which is formed is an IgA antibody rather than an IgG antibody. And then, of course, you have drug-induced pemphigus and the rare variants like endemic pemphigus foliaceous, which occurs in some parts of the world and has also been connected to an insect vector. Now, foliaceous versus vulgaris. So foliaceous, as you can see from the picture, the blisters are not really visible because these are very superficial subcorneal blisters. So you don't usually get to see the blisters in clinical practice. They're so fragile that they will break down almost immediately. You usually do not see the intact vesicle or bulla. But what you will see are multiple areas of crusted scaly erosions. Whereas in pemphigus vulgaris, similar to the pictures that Dr. Ishwar showed you earlier, is a much more severe blistering disease. So here you can see this little yellow thing here is actually a bulla filled with pus. So you have these kinds of flaccid, thin-walled bullae and vesicles, which break down to leave behind large raw areas of denuded skin. These are called erosions. And typically, pemphigus vulgaris also causes mucous membrane involvement. So you can have mucous membrane involvement exclusively in terms of oral pemphigus or ocular pemphigus, or you could have the mucous membrane involvement preceding the onset of skin lesions. In pemphigus foliaceous, as a rule, there is no mucous membrane involvement. So again, to just recapitulate the differences, the reasons for the clinical differences in foliaceous and vulgaris is the fact that in foliaceous, you have only anti-desmoglein 1 antibodies, whereas in vulgaris, your main antibody is anti-desmoglein 3. You could also have anti-desmoglein 1. And this is the reason for the location of the blister as well as the involvement or the lack of involvement of the mucous membranes. Now, I already told you in foliaceous, it is a subcorneal split, whereas in vulgaris, it is a suprabasal split. This is quite a favorite question for entrances. So if you understand the pathogenesis, it's easy to decipher the level of the split. And again, like I said, you have fragile superficial blisters in foliaceous, which you may or may not see, and which lead to dry crusted scaly erosions, whereas you have intact flaccid blisters and wet raw skin in vulgaris. There's no mucosal involvement as a rule in foliaceous. It tends to be a less severe disease, although more chronic and usually not life-threatening. Whereas vulgaris is one of the important causes of acute skin failure. You can have very extensive cutaneous lesions, extensive loss of skin, and it can be life-threatening. Now, just to understand a little bit about pemphigus versus pemphigoid, because this is another thing that, that you need to know clinically as well as for your exams. So in general, you need to remember that the pemphigus group of diseases are intraepidermal blistering diseases, whereas the pemphigoid group of diseases are subepidermal blistering diseases. And that automatically derives from the pathogenesis. So because you have anti-desmoglein antibodies in pemphigus, it tends to be an intraepidermal disease. And because you have anti-hemidesmosomal antibodies in bullous pemphigoid, it tends to be subepidermal. Also, patients with bullous pemphigoid tend to be older. They may or may not have mucous membrane involvement, but it's uncommon. They tend to have very tense and firm blisters. So as you can see from the picture also, the blisters tend to be quite tense in bullous pemphigoid. And this is because the roof of the blister is formed by the entire thickness of the epidermis. So it's a tougher blister to break. Whereas in pemphigus vulgaris, it's an intraepidermal blister. So it's quite fragile, it breaks down easily. Another important difference to remember, the entire pemphigus group of disorders have what is known as the Nikolsky sign positive. So Nikolsky sign positive is nothing but an extension of the microscopic acantholysis that's occurring. So because your structural integrity of the epidermis is compromised, there's loss of cohesion between the keratinocytes. When you apply tangential pressure either at the edge of the lesion or on a bony prominence, the skin can shear off. And this will not happen in the pemphigoid group of diseases because there is no problem with intercellular cohesion in bullous pemphigoid. So generally, pemphigus vulgaris tends to be a more severe disease with a poorer prognosis, whereas bullous pemphigoid can go on for years and patients can continue to live a normal life because it tends to be a milder disease with a tendency to heal on its own even without treatment. Now, the gold standard for the diagnosis of these autoimmune blistering diseases is something known as immunofluorescence. So, immunofluorescence is nothing but picking up antibodies that are either deposited in the skin or antibodies that are circulating in the serum of the patient's blood. So, this is a picture of antibodies that are deposited in the skin. So, what happens is when you have anti-desmoglein antibodies sitting on the surface of the keratinocytes, if you add a fluorescent anti-human antibody to that skin section, it will go and bind to these pathogenic antibodies. And when you look at this under an immunofluorescence microscope, it will give you the location of the antibody deposition. So as you can see here, the entire thickness of the epidermis is lit up. And this is what is known as a fishnet pattern. So you can see that there is a layer of antibodies around each individual keratinocyte. The greenish yellow color is where the positive fluorescence is occurring. So this is what is known as a fishnet pattern. You see it in both vulgaris as well as foliaceous. Whereas conversely, in your pemphigoid group of diseases, you will see a linear band-like infiltrate in the basement membrane zone. That's because this is a subepidermal blistering disease and your antibodies are targeting the hemidesmosomes, which are located at the dermoepidermal junction. So this is direct immunofluorescence, and this is what is used to diagnose these diseases. Now, coming to treatment of pemphigus, I'm not going to go too much in detail into the clinical presentation because you can have very mild forms to very severe forms, which result in acute skin failure. But suffice to say that you should be able to identify at least a patient with a blistering disease, because very often we have patients in OPD who come to us with a history of, say, a year or 2 years of oral ulcers, non-healing oral ulcers, and they've been treated by several people, including general physicians, ENT, dentists, and nobody has been able to pick up the fact that this patient could actually be having pemphigus. So non-healing oral erosions is a sign, and also the cutaneous lesions. Once cutaneous lesions develop, it's easier to pick up. So coming to treatment, the mainstay of treatment for most of these diseases, because they are autoimmune diseases, is immunosuppression. So a long time ago, something known as gold salts used to be used for the treatment of pemphigus. This is no longer being used clinically. And then for a while, we used something called dexamethasone cyclophosphamide pulse therapy, or DCP pulse therapy, where we used to use very high doses of dexa and cyclophosphamide and give the patients an intravenous pulse once in a month. So that's also gone out of vogue now because we have a treatment called rituximab. So rituximab has now become the therapy of choice for the pemphigus group of diseases. It's a very good therapy in terms of its specificity. So rituximab is basically an anti-CD20 monoclonal antibody. So anti-CD20 meaning it targets the B cell. CD20 is a B cell marker. And when the B cells are targeted, antibody production will stop. So it's much more specific than the global immunosuppression that you see with steroids, azathioprine, cyclophosphamide, all your other immunosuppressants. So rituximab has become the mainstay of therapy along with small doses of systemic steroids for pemphigus now. So moving on to the next group of diseases. So I'll tell you a little bit about Stevens-Johnson syndrome and toxic epidermal necrolysis. This is again because it's important to be able to recognize these disorders early. Typically, SJS and TEN are drug-induced, although there are rare cases where there could be absolutely no drug history and it could be caused by an infection. So histopathologically, these diseases are characterized by what is known as interface dermatitis. Interface dermatitis, as you can see in this picture, is nothing but an infiltrate of lymphocytes into the dermoepidermal interface. So what you have here above is the epidermis, and below you can see that there is an infiltrate of lymphocytes, the blue dots, into the skin. And along with this, because of this lymphocytic infiltrate, you get what is known as epidermal necrosis. So all this entire group of diseases has epidermal necrosis as a hallmark. Now, this is just a list of the common drugs that can cause SJS-TEN. But virtually any drug, it's important to remember that even your innocent paracetamol could also be the cause of a drug reaction. So never rule out any drug. And it's also important to know this list because till date, we do not have a diagnostic test for finding out which drug is responsible for a drug rash. So the only way you can find out is by taking a detailed history, find out repeated exposures, and also you can assign what is known as a probability score. There are several probability scores available. You can assign them, calculate and assign them to each individual drug. But there is really no in vitro or in vivo test that will tell you that, okay, this patient's rash was caused by carbamazepine or phenytoin or nevirapine. There is no test like that. So it's important to know at least broadly which are the drugs. So the common offenders are antibiotics. Among the antibiotics, you also have the sulfonamides. Anticonvulsants are a next big notorious group that causes SJS-TEN and a lot of other drug rashes as well. Then you have your ATT, ART, and then of course your ubiquitous NSAIDs, which any patient in India can get virtually over the counter. Now, the reason why I'm showing you this as a spectrum is because this will also help you understand the clinical presentation of these diseases. Although EMF basically is erythema multiforme, it does not really belong to this group, but you can consider it as the lowest or the mildest end of the spectrum of these diseases because the pathogenesis is similar and the clinical presentation is connected to SJS-TEN. So a little bit more about that. After EMF, you have SJS, SJS-TEN overlap, and TEN. So these are virtually the same disease, the only difference being the extent of epidermal detachment. So when you have only less than 10% of the body surface area involved, you call it SJS. When it crosses 30%, you call it TEN. So it's just a matter of semantics. When it's somewhere in between, say a patient has 20 or 15% involvement, it is called SJS-TEN overlap. Okay, so there's otherwise, broadly, there's really no difference between SJS and TEN. Now, a little bit about EMF. You need to understand the primary lesion that occurs in EMF for you to be able to understand and identify the lesions that occur in SJS-TEN. So this is your typical lesion in EMF. This is what is known as a raised or a typical target. Now, a raised or a typical target, otherwise known as a bullseye lesion or an iris lesion, as the name signifies, it basically has a central area of either duskiness, or if the epidermal necrosis is severe enough, it can even blister. So you can have a dusky center or a vesicle in the center. You have a peripheral pale edematous area, and then the last ring is an erythematous ring halo at the periphery. So this looks like a dartboard, isn't it? So this is why this is known as a target lesion. So your typical targets, that is this kind of target, which has all three components, that is the central area, the peri-lesional edema and pale color, and then the erythematous halo. You have to have all three components to call a lesion a typical target. Now, typical targets usually occur only in EMF. So EMF lesions are quite easy to identify. There's virtually no differential diagnosis in dermatology for these lesions. You have lesions distributed, it can be all over the body, but more typically on the acral areas like hands and feet. And you can have a lot of mucosal involvement as well. So here you can see eye involvement and lip involvement. Now, typically EMF is not always drug induced. It's more commonly infection related. And the most common infection that can precipitate EMF is herpes simplex infections. So in that sense, both in terms of lesions as well as the trigger, it tends to be quite different from SJS TEN. So coming to SJS and TEN. Now you can see here that the lesions have a tendency to form targets, especially here. So you can see those round bullseye kind of lesions, and the same lesions becoming larger with much more necrosis in the center and then coalescing to form sheets of necrosis. So these are the hallmark lesion of SJS-TN. They are what is known as flat atypical targets. So unlike your EMF targets, these tend to be flat. And unlike your EMF targets, these will not be typical targets. They will be targetoid, or they will lack one or more of the components of your typical target lesion. And again, you have extensive mucosal involvement in both SJS and TEN. So this is a picture of SJS. When you move into the TEN spectrum, it is basically the same thing, but with much more extensive surface area of involvement. So this is actually one of our patients. So you can see the extensive mucosal involvement. This patient had eye involvement as well, genitalia too. And you can see that the skin peels off in sheets. So there are sheets of epidermal necrosis. And here on the right is how the skin pigments after the resolution of this disease. So TN is a disease with a high mortality, and it's understandable, isn't it? When you have such extensive skin loss, you are prone to all the various complications that can arise out of skin loss. So these patients essentially behave like burns patients. In fact, in some parts of the world, TN patients are managed in burns wards. So how do you decide how bad or how mild TEN is? So there is a scoring system known as score 10. So score 10 is basically a combination of 7 factors. So you assign a score for each of these and you get a total of maximum score of 7. So 3 of them are biochemical parameters and 4 of them are clinical parameters. And you assign, add it up, and then it gives you a rough idea of mortality. Like for example, you have a 60-year-old patient with tachycardia, with an underlying malignancy, and say, for example, a detachment of about 30%. This patient will get a score of at least 4. So if you have a score of 4, the mortality rate tends to be 58%. So that's pretty high mortality, which doesn't normally occur in other skin diseases. TEN is one of the most fatal drug reactions that you can have. So that's about score 10. Now coming to treatment of SJS-TEN, there's really no specific drug that can reverse the pathogenesis of SJS-TEN. Just like there is no specific test to find out which drug caused the disease, you also don't have a specific treatment till date. We'll come to some of the treatments that have been used and that are being used. But essentially, your first step in the treatment of SJS-TEN is to identify. Your identification, early identification itself is half the battle won, because you can refer. And once a patient has been diagnosed and referred, the first thing to do is to stop the drug. Even one single additional dose of the drug should be prevented as much as possible. You transfer to a center, and like I said, sometimes some of these patients are managed in ICUs and in burn centers because they have such extensive skin loss. Supportive care is the prime thing that determines whether a patient with TN will do well or not. So like Dr. Ishwar mentioned, they have a lot of loss of fluids, electrolytes, they're prone to sepsis, they have nutritional losses. So these patients require a lot of supportive care. And then comes the question of active intervention. So active intervention for SJS-TEN again boils down to these three drugs. These are the drugs that we commonly use: systemic steroids, cyclosporin, and IVIG. IVIG much more in the Western world because of affordability issues in India. It costs a few lakhs to give a patient IVIG here. We have given a few patients, particularly children, because the dose required is smaller. But more or less, these are the two drugs that we use: corticosteroids and cyclosporin. Now, one of the reasons I put up this chart is because one is because SJSTN doesn't have a drug of choice or any specific therapy of choice. And the other reason is I just wanted to introduce you to this concept of grade of recommendation and level of evidence. So when you read literature for diseases like this, where there is no clear-cut therapy that is recommended, you have to go by the available evidence. So going through the literature for evidence is something that all of you must familiarize yourselves with, because as you go out into the big bad world, you will come across unusual diseases or diseases for which there is no chart or table in Harrison's or Davidson to help you manage. So that's when you go into the realm of literature. So just to sensitize you to what these are, so these are levels of evidence basically. So levels of evidence, your highest level of evidence will be systematic reviews and meta-analysis of RCTs. So that is the best available evidence that you can have for any intervention or therapy. Then you have your RCTs, randomized controlled trials, are again a good level of evidence. Then you have cohort studies, and all the way at the bottom you have your case series and case reports. So case series, say one patient somewhere in Tunisia was treated with say plasmapheresis for TEN. That is not a good level of evidence. It's the quality of evidence becomes less because it's anecdotal. So as you go up this pyramid, your quality of evidence becomes better and better. So as I said, your meta-analysis of RCTs and your RCTs, these are the highest level of evidence. So this would be level 1 evidence, whereas expert opinion, case reports, observations, etc. become level 5, and everything else comes in between. So as you can see here in this chart, the level of evidence for many of these drugs for SJS-TEN is a level 2. It's not a level 1. And your grade of recommendation again depends on the strength of the evidence. So if you give a grade of recommendation A, that means that that is the drug of choice. If it's B, then that is the drug of choice mostly. If it is C and D, then the evidence is plus minus, but you can take a call based on the risk benefit analysis. So again, you can see here some of the, like see for plasmapheresis, it is C, and for none of them, it is A. So this is something that you should familiarize yourselves with and learn to understand when you're reading literature as to how strong the evidence is for a particular therapy. So coming to the last disease in the set of diseases that I'm going to be talking about today is Staphylococcal scalded skin syndrome. So as the name suggests, this is a bacterial toxin mediated disease. It's otherwise called Ritter's disease. And please note, this is different from your Ritter's disease or Ritter syndrome, which is an entirely different condition. So this is basically caused by an epidermolytic exotoxin of Staph aureus. An epidermolytic, as the name suggests, means that it causes epidermolysis. It causes loss of cohesion between the keratinocytes. In fact, it almost mimics the action of anti-desmoglein 1. Staphylococcal scalded skin syndrome, typically in clinical practice, you will see in children in infancy, usually below the age of 1 or maximum below the age of 2 years. And very rarely, you can also see it in elderly adults, adults with renal failure, adults who are immunosuppressed. You don't normally see staphylococcal scalded skin in between. In healthy young adults and older children, you don't usually see because the body has achieved the capability to excrete the toxin. So wherever your renal system is immature, like in a very young baby or in a very old adult with some comorbidity, usually the healthy individual is able to excrete this toxin. So staphylococcal scalded skin syndrome will present with an extremely irritable child. Sometimes the irritability and the cutaneous tenderness, the child will scream when you even just pick up the child. And this can occur up to 24 to 48 hours before the actual onset of skin lesions. So skin lesions usually in SSSS, the typical presentation is as you can see in the first picture, in the first panel. And here you can see the peri-orificial, that is periocular, perioral, and around the neck, and also in the folds and genitalia. So this is the classical presentation of staphylococcal scalded skin. And why it's called scalded skin is because it actually looks like a scald injury, like how you get when you pour hot water on yourself. This is how the SSSS patient will look. There will be very superficial blistering and peeling of the skin. Again, the level of the split in SSSS is quite superficial. It is at the level of the stratum granulosum. So almost like pemphigus foliaceus. But unlike the pemphigus group of diseases, SSSS has a reasonably good prognosis. So if it is caught early and the patient is treated with systemic IV antibiotics, usually they do well. Again, you need supportive care for a short period of time till the skin epithelializes. But with antibiotics, usually within 48 to 72 hours, you will see good epithelialization. And in children, the mortality is very low. It's less than 5%. Whereas in older individuals, adults, immunocompromised people, the mortality can be as high as 50 to 60%. So SSSS is one of the diseases in dermatology that is very gratifying to pick up and treat. It's important to remember the age group, because in this age group, you don't usually expect to see your other diseases like blistering diseases, autoimmune bullous, SGSD. And although all these are also differential diagnosis for SSSS. So if you give systemic antibiotics, it's a very gratifying disease to treat. So that's it from me. I'm happy to take questions if any of you all have anything to ask.
Thank you, ma'am. If anyone has any questions, please drop it in the chat box. Okay, please write to us later if you want anything clarified later on. But thank you so much, ma'am, for shining, I would say, fluorescent light on pemphigus, SJS, staphylococcal scalded skin syndrome, and all of the other blistering conditions of the skin, with an important and I would say quite relevant touch on how to review literature. And thank you, ma'am, and thank you, Ishwar sir, for taking the time on a Sunday afternoon to speak to the students about this topic. Thank you so much, ma'am.
Thank you, Dhwani.
Thank you, Dhwani. Thank you.
With that, we conclude the dermatology section of today's lecture series, and we jump into the wellness series, where we have two talks given by two eminent personalities, two eminent healthcare workers in the field. Our first talk is by Arun Stephen Sir from the Department of Physiotherapy in St. John's Medical College Hospital. He'll be speaking to us on the importance of ergonomics in a profession, with a special relevance to medical students, healthcare workers, and software professionals. Sir, over to you. Are the slides visible?
Yes,
Yes, ma'am.
yes.
Oh, I don't think it's changing.
Okay, good evening, everybody. Can everybody hear me? Am I audible?
Yes, yes, you're audible. Go ahead.
Are the slides changing?
Yeah. Yes, yes, it's being changed. Okay, is it visible now to everyone?
Yes, visible.
Good evening, one and all. Thank you so much to the Innovative 2022 organizing team for giving me the opportunity to talk to you all about ergonomics and in ergonomics, physiotherapy perspective. I think hope most of the students, many will be knowing what do you mean by ergonomics. Okay, it's a science. It's of two words. Ergon means work, and normos means laws. Okay, it's a study of people in their workplace, and there's a process in which workplaces, products, and systems are designed or rearranged so that they fit the people who use them. So mainly how the people are getting adapted to their workstation and the environment where they are working in. Okay, mainly ergonomics aims to improve the workspaces and environments to reduce the risk of injury. Okay? The position which they're maintaining when they work, okay, it matters a lot. Okay, when you're looking into the ergonomics, we know what exactly how the individual should position themselves when they're doing their work, so that the uh, risk of injury can be prevented. Okay. Next slide. Okay, so we need to balance the job demands as well as the worker capabilities. Mainly, a balance for optimization is needed in ergonomics. Mainly, we need to fit the task to the worker rather than forcing them to work or adapt to the working environment. Mainly, the designing the workplace to prevent occupational injury and the illness. Okay, the process of identifying preventing work-related musculoskeletal disorders. So mainly, when coming to the techies or even the students, when they're sitting for long duration in a class, or if the IT techies were sitting in front of the system for long duration, they tend to have a bad posture which they are maintaining. Eventually, when they work for long durations, say for 6 to 8 hours, or 10 hours, 12 hours, work from home, all those. So automatically they adapt a bad posture, which end up with back issues or neck pain or shoulder pain or the wrist pain. Okay, so mainly ergonomics will it identifies the work-related problems and then the related musculoskeletal disorders. Next slide, please. Okay, so what are the process of this ergonomics? Mainly this ergonomics, it assesses the risk of the work which we are doing. Okay, and then after assessing, we plan according to the changes which they're having. A proper plan has been implemented so that the musculoskeletal issues and risk factors can be improved or prevented further. And then it measures the progress, like when they're continuing with the change of adaptive postures, how they are responding, whether still they're having the backaches or neck pain or something. It measures the progress, and then it scales the solution also. Can you have the next slide? Okay, so why it is important? Why ergonomics is important? Okay, so as I told you, in the workplace, when you're sitting in a bad posture, maybe the room temperature is extremely hot, or if it is too cold because of the AC, or if you're doing any repeated movements, particularly sitting in the same position every day, and uh, that will cause lots of problem to the musculoskeletal system that may affect eventually. So it won't happen within one day. So eventually it happens because if they're maintaining the same bad posture, so they may end up with back issues one fine day later on. Okay, so ergonomics plays a major role in reducing the work-related injuries. Uh, Injuries or illness like computer vision syndrome or neck and back pain or carpal tunnel syndrome. Okay, so computer vision syndrome is mainly it involves more of eye dryness or irritations or blurred vision double visions, all the same. And then, as you all know, neck pain and back pain is a common issue which is encountered from the people who are sitting in front of the system, or even the students that sit attending the class for long duration from 8:30 to 4:30. Okay, I mean, even when they use the system, they tend to get this carpal tunnel syndrome where the median nerve is getting compressed at the wrist level in the carpal tunnel. So they end up with a tingling sensation and pain at the wrist and then to the hand. Next slide. Okay, so we'll discuss about the acute and then the cumulative disorders. Acute means acute injury, or a cumulative disorder means, like, for example, acute injury means like a cut by a knife or a blade to your finger. Okay, that's an acute injury. Accidentally, it happens. Whereas a cumulative injury mainly results from repeated wear and tear. Okay, so continuously when they sit in the wrong positions, in the beginning the muscle will get adapted to that particular position, and then longer period when you're maintaining the same position, the muscle will get fatigued, and then one fine day with some incident, it may end up, it will flare up with the big issues. So it may look like it's an acute injury, but rather it is a chronic injury which has been, the strain has been accumulated for many days. Okay, so then they end up with back pain or neck pain or whatever pain they get onto the joints. Okay. So what are the other domains of specialization in ergonomics? Okay, according to this International Ergonomic Association, there are three major domains of ergonomics. One is physical ergonomic, another one is cognitive, and the other one is organizational ergonomics. So in this, we'll discuss more about the physical ergonomics. So the physical ergonomics is the workstation where we are working. This is an example when you're working on a system. Okay, so the position of the head, neck, shoulders, elbow, and then the hip, knee should get aligned to the computer which is there in front of you. Okay, the position of the neck. Say, for example, if in this picture we can be able to see that the angle, viewing angle, and then the distance between the eye to the monitor, it is 14 inches. Okay, 14 to 24 inches approximately, and then the inclination of viewing angle should be that much, almost 20 to 30 degrees should be declined. In case if the system is little more lowered, so automatically the view point from the individual will be much more tilted. Automatically, it will end up with more flexion of the cervical vertebra, with more neck will be flexed. So automatically, when that is continued for longer duration, looking for 6 to 8 hours or 10 hours, so they end up with back pain. So along with that, so if they're maintaining a forward neck position, automatically even the shoulders also will be protruded forward. So once that is protruded, they tend to have a kyphotic posture at the thoracic spine. So once there is a forward neck posture and then rounded shoulder and then a kyphotic posture under the thoracic spine, they end up with loss of lordosis and the lumbar region. Actually, you can able to see there is a lumbar support which is maintained to maintain the lumbar curvature. So once the lumbar curvature, the lordosis is not maintained, if there's a flat back on the lower end, again the complete shape of the spine, the normal primary and secondary of the spine will be altered, ending up with spinal involvements or muscular aches. So other than that, even the shoulders and then the elbow and then the wrist also has to be maintained in the proper position. So the shoulder should be adducted and then the elbow should be maintained in 90-degree flexed position. So again, in for example, if the keypad has been raised, elevated than the to maintain the distance, so they tend to just elevate the shoulders where the upper trapezius will be activating so much. Okay, so again they tend to have trapezius which has been maintained for a long duration. Okay, so the shoulder also has to be maintained, and the shoulder and the elbow has to be maintained in the adducted position as well as elbow with 90-degree flexed position. And then working on the keypads, mainly the wrist also should be in neutral position. So these are things which has to be mainly followed when you're looking into the physical ergonomics. Okay, even the seat height, chair seat height also has to be maintained. If the seat is too lower, they tend to just flex their hip and knees so much. Okay, even the hip should be at an angle of 90 degree, and then the knee should be at an angle of 90 degree, and then the foot should be in the neutral. Plantar flexion, dorsiflexion position should be in neutral positions. Next slide, please. Okay, so next comes the cognitive ergonomics. It is mainly concerned with the mental process, such as the perception, memory, and then the reasoning, and then the motor response. How this mental process helps in interacting with the humans. Okay, the people whom they're working with in the organization. Okay, so this is little away from the physiotherapy aspect. Okay, and then the organizational economics, again, it refers to the optimization of the social technical system, which includes the teamwork, job shifts, and then the work satisfaction schedules, and then work ethics. So what are the benefits of ergonomics? Okay, so once the workstation or the uh, atmosphere where the individual is working is good enough, if they don't have any back musculoskeletal issues, then there is more reduced chance of risk of work-related injuries and illness. So automatically they will not end up with back pain or leg pain. Obviously, then because of that, like they tend to come to the work regularly without taking a leave or something, sick leave. Okay, and then the productivity also will increase, and then the health also will improve, and then the mental insights also will improve. Product quality also will happen, and then the pain also decreases. End of the day, the employee will be happy enough, and then they'll engage themselves in the work well, and then ending up with the proper good safety culture. So I'll tell you some common upper extremity cumulative trauma. The CTD is nothing but cumulative trauma disorders. So which happens eventually, like as I told you on the previous slides, like it happens eventually after a few weeks, a few months, if you're following the same posture, same position which you're maintaining. Okay, so like and then they end up with tendinitis, tenosynovitis, trigger finger, epicondylitis, or thoracic outlet syndrome, carpal tunnel syndrome. So tendinitis is nothing but an inflammation of the muscular tendons junction, where the repeated movements they end up with this tendinitis. Even the tenosynovitis. So the inflammation of the synovial membrane, which is surrounded by the tendons. Okay, and then the trigger finger, as you all know, more of the flexor tendon, which is getting involved. Mainly the middle finger, the index finger will be involved, where the flexor tendons will get swollen, and then it will get entrapped inside the tendon sheets, where actively they may not be able to just extend after the fingers are flexed. So passively only it can be extended. And in epicondylitis, mainly it's lateral epicondylitis, mainly when they're working on the system. Because repeatedly when the wrist is extended and the fingers, the middle finger and then the index fingers are flexed and extended using the mouth for right click and left click, automatically the external carpi radialis longus brevis muscle get worked out so much, fatigue, ending up with lateral epicondylis. The other name it is tennis elbow, where the common extensions of wrist and then fingers getting inflamed. Okay, and then thoracic outlet syndrome also happens. Why? Because when they have a rounded shoulder, automatically the space between the clavicle and the first rib will get encroached, where the subclavian neurovascular bundles are compressed, leading to pain onto the shoulder, elbow, and the tingling sensation to the hands. And then carpal tunnel syndrome, as I told you in the beginning, so it's more of median nerve compression inside the carpal tunnel, narrowing of the carpal tunnel leading to compression of the median nerve, causing more pain to the wrist, pins, and parastitial at the hand level. Next slide. Okay, so there are two kinds of back injuries, predominantly people when you're working on the system or students who are sitting for long duration. Okay, so one is the muscular involvement, muscular back injury, other one is the spinal mainly. So usually any person who sits in the wrong position for long durations, usually in the beginning, the muscles get fatigued. If it is, we call it as repeated stress syndrome. Okay, continuously when they sit in one particular position, okay, without changing the position, they end up with muscle aches. Okay, so when that is been continued, so the muscles give up, and then the the more stress goes to the spine, starting from the cervical spine to the lumbar spine. Okay, and in the spine mainly the disc get involved. So there is a disc degeneration which happens eventually, and then there is no direct blood supply to the disc. So that causes early degeneration when there is a continuous stress which is given to the back, lower back, or to the upper back. Next slide. Okay, so what are the other risk factors for this musculoskeletal issues, mainly a repetitive motion which has been happening to the joints. Okay, repetitive movements, like whatever it is, like when you're sitting in the continuous similar position, or when you're doing a repetitive movements where the most stress and strain goes to the joint. Okay, and then a forceful exertion also. If you're lifting any heavy weights repeatedly, or more than the expected weight, if you're trying to lift, sometimes that will also end up with a risk of leading to back pain or neck pain. Okay, and then direct mechanical pressure, and then the static posture which you are maintaining for a prolonged time, okay, without change of position. If you are maintaining the same position statically for long duration, and then inadequate recovery time. So if you're having an acute injury, if you're injured, and then uh, without giving any proper rest or proper recovery time to it, again, if you're straining to strain that particular affected area, then again it is a risk factor. And then the awkward position, which is commonly maintained by everyone when you're sitting in front of system or when you're sitting for long durations. Okay, and then the environmental stresses, mainly the room temperature, and then the loss of air circulations, all those matters, okay, leading to risk factors. Next slide. Okay, so these are the design strategies to prevent the back issues, mainly. Uh, when you're trying to just lift any weights, whatever weight it is, if it is too heavy or if it's too low or something, so when you're trying to lift the weight from the floor, make sure that the weight has been held towards your trunk. Okay, it should be the distance between your body and then to the weight which you're carrying should be shorter. So the more you're keeping the weight in front, okay, you tend to strain your lower back, mainly the lumbosacral region is getting strained. Okay, so when you try to lift any weights, make sure that you're keeping the weights closer to your trunk. Okay, and then so like you need to minimize all this pushing and pulling of weights, then minimizing the load weights, avoiding heavy lifting of weights. Instead of lifting, you can just try to slide the weights. So all these are the design strategies which can just prevent the back issues, back pains. Next slide. So these are the assessment, mainly when you're working on a system. The assessment which has to be maintained, mainly that the display screen equipment workstation checklist. Mainly this the keypad which has been kept in front of you, the distance between the keypad and then to the hand, how we are pushing, how the elbow and shoulder should be pushing. So the first picture shows how an ideal position of uh, using a keypad. The other three has means the elbow is extended in the next next picture, second one, and then third picture. It is too much flexed, the elbow is too much flexed. Again, the last picture shows like you are having a the person is having a slouched position. Okay, so again there will be a altered portion of the cervical spine or the thoracolumbar spine. Next one. Okay, next comes your use of mouse. Okay, the ideal position of the mouse where you can able to reach easily, and then again the mouse should not be kept little away from your reach of your hand. Next slide. Okay, and then even the display of the screen also matters. Okay, whether the font size is it easily readable or whether it's clear, and the text size also matters. In case if the texts are not so clear, if the font is very small, we tend to just focus on the letters, and then automatically subconsciously we tend to just protrude the neck forward to reach for the letters. Okay, when the fonts are small, so small. Okay, again, if it is if the image is not fixed, if it is very unstable or flickering, again you tend to just have altered position of the neck and head. Next slide. Okay, again the screen distance from the eye level to the screen distance, how whether the screen monitor has been tilted or not. Okay. Okay, and then whether the screen is free from glare and reflections. Again, if there is any reflection or if there is any glare, we tend to just alter our neck positions. If it has been reflected, like automatically, you tend to have a flexed position or an extended position of the neck. which alters your idle position of your neck when you're looking at a monitor. Next slide. Okay, and then the furniture which you're keeping it next to your system, when if it is too much crowded with other things, you tend to just change the ergonomical position of your computer system. Okay, so make sure that on the table we have only the monitor and then the keypad and then the mouse. And then next slide. Whether the seat is adjusted correctly or not, this also matters a lot. Okay, because when we have a bad wrong so I mean, wrong position of the chair. Okay, so automatically you tend to just flex forward so much, or you tend to extend your neck. Okay, ideally the spine should be, the thoracolumbar spine should be erect enough, and then the shoulder should be retracted back. Okay, so that your head level, eye level goes exactly in line with the monitor. Okay, so what are the preventions for this musculoskeletal issues, and then what are the physiotherapy interventions mainly? Okay, so main thing is like we need to just create an awareness to the individual about the ergonomics, the idle position which they're supposed to maintain when they're sitting in front of system, or when they're trying to do any kind of job pertaining to the IT field, the people who are sitting on the system I'm talking about. But not only that, even any other laborers who are working, the way how they are supposed to lift up, all those should be explained, and then awareness. They need to be educated about the ergonomics first. Okay. Next comes the proper positioning. So once you're teaching them the awareness about the ergonomics, automatically they learn the exact proper positioning which they need to maintain when they're working in their work environment. Okay, and then when it comes all these things along with that, there should be some flexibility exercise as we maintain. Why? Because if the body is not so flexible, say for example, when you tend to just take some, if a paper is fallen down from a table, you tend to just flex forward and then reach for the paper. Sometimes you end up with kind of strain to the back or to the shoulder. Okay, so this shows that like your body is not flexible enough. Okay, so the flexibility exercise will help you, and it will make your muscle ready for your work which you're doing. Okay, the muscle should be ready enough for whatever movements you're doing. So if it is not flexible, automatically the muscle which are not getting contracted, you tend to just force it to contract, so you end up with muscle aches or muscle strains. Okay, so flexibility exercise is very much important, mainly for your lower limb as well as for your trunk as well as for your upper limbs, mainly the shoulders. Okay. And then along with the flexibility exercise, you should train your muscles to have some uh, strength, or a rested exercise should be done. Okay, mainly people who are nearing to 30 third decade or fourth decade, 30 plus or 40 plus of age group, they tend to have lots of degeneration which happens to the uh, tendons, mainly the musculoskeletal junction, where they end up with tendinitis, very common injury which is seen at the fourth decade, mainly the rotator cuff injury. Okay, so during that period, mainly the individual should have some restricted strengthening exercise just to be done. Okay, so that we can just prevent this musculoskeletal injuries. So along with that, even the aerobic activities also should be encouraged mainly. Okay, like we can just tell them to just climb the stairs instead of going on the lift. So all this will improve their cardiorespiratory endurance. Okay, so this, when they follow this, well, when they learn the ergonomic awareness, and then when they maintain the proper positioning, and then when they start doing the flexibility exercise, along with that they do the rested exercise and the aerobic activities, hopefully they will not have any issues when they work in whatever circumstance they're working in. That can, the musculoskeletal ailments can be prevented. Fine. Thank you so much. And do you have any doubts? Can ask me.
Thank you so much, sir. If anyone has any questions, please put it in the chat box. Okay, thank you so much, sir. Thank you for giving this
Thank you.
very unique perspective on ergonomics with a focus on the anatomy and physiology of the musculoskeletal system as well. Thank you so much for your time on a Sunday evening, sir.
Thank you, Dean. Thank you so much.
Up next, we have a very interesting session by Dr. Murtaza Ghia, an alumnus from St. John's, currently a practicing emergency medicine physician, who's also the founder of Code Blue Wellness Solutions, which is an organization meant to improve emotional well-being of healthcare workers with product skills and services, particularly for vulnerable groups like interns, residents, and junior consultants. To motivate healthcare professionals to restructure old hobbies into product skills and services by providing logistical support, and to help monetize product skills and services as an alternative source of income for healthcare professionals. Sir will be speaking on sleep hygiene for sleepless medicos. Over to you, sir.
Hello. Good evening. I'm presuming you all can hear me. And if you can't, you will tell me you can't. But if you can, you don't have to tell me you can. Okay, we'll presume you can. Superb. So we're going to start. My screen is being shared. And yes, so this is okay. My screen, this time you'll have to tell me if you can see my screen. I prefer that.
Yes, sir, it's visible.
Pleasure. Super. So I'm really happy that on a Sunday evening, there are people who can take out some of their evening time, which is probably meant on a Sunday evening, to do something more fun than this, to look at this as a long-term investment. It's going to add to the overall wellness. So I'm really happy that you're here. And I'm happy that I'm making good use of my Sunday evening, which would otherwise be wasted in watching some rubbish on Netflix. So thank you once again. Before we begin the core of this today's discussion, let's just look at this. And I'm sure everyone's looking, some of them with their mouth wide open, like, whoa, this is what's happening in the world. Yes, these are the rates of burnout, but don't get easily carried away by just looking at the numbers. If you look at them closely, you will see that although there is a ranking here, top one rank to the top lowest rank here, to the lowest rank here, all of them are burnt out. And the percentages are very, very minorly different. The take home point here, of course, is that all specialties are rapidly burning out, irrespective of where they practice and what they practice. Then comes the question, how do you cope with this burnout? I have gone through this myself. I've sought help from professionals. I've taken breaks from my career to just fix this problem for myself and then go on to help younger colleagues, sometimes even older colleagues. So I've read this fantastic article, and I've also gone through this when I worked in the UK, this manual. And we've understood then that there are multiple factors that lead to burnout. From these articles, we picked up 7. As you can see, these 7 factors that lead to burnout. Number 2 is sleep-wake cycle disruption. In some ways, it's also the hierarchy. It's probably the second worst problem, second worst factor that's leading to rapid burnout of healthcare professionals. So we're going to discuss this in some detail today. But before that, we'll just divert a bit to talk about Code Blue. It's India's first wellness startup exclusively for healthcare professionals and exclusively by healthcare professionals. As you can see here, we are a registered company. We're really small, but we're slowly growing with everyone's help in understanding how business works and how it works for healthcare professionals in this unique sector of wellness. Our vision and mission is, of course, to fight burnout through skills, products, services. We are targeting the vulnerable groups most because they are the ones left out from all such initiatives. We are trying to bring in old hobbies and rekindle that fire, providing logistic support to young doctors, nurses in largely trust and government hospitals which are underfunded, where the youngest healthcare providers are often sacrificed. Some point, we hope that we are able to create an alternate source of income for doctors and nurses through their own hobbies. We are still trying to work on the business model. We'll need a lot of help from good friends and well-wishers and the big family of Code Blue, of which you all are a part of now. So Code Blue, I'll just give you some quick examples. Dr. Linda, co-founder, she's a dermatologist, and she always complains that somewhere while doing MBBS, she lost her hobby of playing with dough, playing with clay. And now, after being a practicing dermatologist, she's gone on to make some home handmade soaps, healthy for the skin. She's gone on to make her own unique recipe for protein bites. And this is her poster. We're trying to sell these products for her. There's also another doctor who suffered a lot during internship, various types of illnesses. She fought back and made this wonderful wellness calendar for healthcare professionals. Again, we are trying to have these sold on her behalf. We've done multiple events during COVID. We went, convinced the dean of this COVID center in Mumbai, got paid for this event, and we did a painting event during COVID for all the doctors and nurses, some glass painting, as you can see. We went on to do open mic poetry events for doctors in various languages across India, all types of specialists, all ranks from junior to senior, as you can see here. Some fantastic reviews for us from there. We went on then to do a couple of guitar workshops in various institutes. As you can see, the guitar trainers are all doctors. And the USP of this is that we do it during work hours, getting permission from the dean, such that residents, while they are working, interns, while they are working, can come and get hands-on. So this is not a talent show where somebody's showing off how well they can play, but it's making sure everybody gets to hold the guitar, feel it, understand what it is to practice a hobby while going through the grueling period of internship and residency. Some letters of love from us, from all these young doctors, and some of them nurses also. We went down to do a photography online event, and it's surprising how a cardiothoracic surgeon has so much energy and so much dedication towards photography and still pursuing it. Yes, one of our good friends, an ENT surgeon, then did a painting virtual event for us, which also went very well. We had a picnic in Bangalore where we got doctors coming in from duty, doing silly things and making sure all the other participants also do those silly things with them. And mind you, very few of these people actually know each other. They've just got together because of Code Blue, and they've gone on to become good friends. Similarly, in Mumbai, a little off Mumbai, we had this fantastic picnic. Again, some of them doctors, dentists, nurses, psychologists, Ayurvedic practitioners coming together, sharing thoughts on wellness and just having a good time. Coming back then again to today's discussion, which is sleep hygiene and for sleepless medicals. So let's talk about the sleeplessness, which is our real problem issue first. As you can see from the annals of emergency, annals of medicine and surgery, we have this study which talks about sleep disorders amongst medical students. It's baffling to see this statistic from here. As you can see, hypersomnia is there in almost 25% of medical students, and insomnia is there in almost 20%. So we are actually talking about 1 in every 4 to 1 in every 5 medical students having some form of sleep disorder. So these numbers are staggering. Moving on to something more intense. So what does this lead to? This is a study by the American College of Cardiology. This study is talking about what sleep duration does to your risk for myocardial infarction. Please hold your breath because this is going to be very, very interesting, a little scary, but nonetheless interesting. So the study is a prospective study done over a duration of 7 years, involving more than 450,000 participants, and almost 5,000 of them over the period ended up with NMI. We believe that looking at these numbers, looking at the journal, this is a good quality study. So we're going to do this in a bit more detail now. The study went on to divide subjects into 3 categories. The short duration sleepers, let's call them the undersleepers, who slept 6 or less hours. The long duration sleepers, who slept for 9 or more hours. And the reference group, which is a bit 6 to 9, or you can say 7 to 8 group, 7 to 8. And those were the, let's say, balanced sleepers. Okay, so these are the three groups. Now let's look at the first result that they came out with. The undersleepers who slept less than 6 hours had a 20% higher risk for incidental myocardial infarction. All right, the hazard ratio, as you can see, is 1.2, which is significant, and so is the confidence interval. Moving on to the oversleeping category, even they had a 34% higher risk. And you can see here the hazard ratio is 1.34, but the confidence interval being a bit wide brings about a few questions here. Nonetheless, we'll go on to the second half of the results. Let's say the balanced sleepers, somewhere between 6 to 9 hours category. It's fantastic because it says this group mitigated. That means they bypassed their risk for MI, even amongst individuals who were considered to be high genetic liability for MI, which then means, as you can see, the hazard ratio is significant, which then means that in some ways, sleep is an independent risk factor for MI, and good sleep can sometimes help you escape MI, even if otherwise, because of a genetic composition, you are likely to get one. This is just for those who are interested in a bit more depth understanding of research. They've gone on then to do a multivariable hazard ratio, and they found something very interesting. So people who are the short sleepers, we know that they are at risk for MI. But when they did a Mendelian randomization, they found that even if you slept up to 7 hours, you're not in such a great position after all. You still have a 19% risk for MI, which then means you could take 1 extra hour and go on to 8 hours of sleep. That's between 7 to 8 hours of sleep. You show that maximum green 20% reduction of MI, which means that if you go above 9 hours, again, the risk builds up. However, through the Mendelian randomization, it was told that the sweet spot was between 7 to 8 hours. Please remember that number. We're going to revise it at the end of this discussion. Further, because it's relevant to other young population, the young participants that are there on today's discussion, even youngsters now are presenting with coronary artery disease. As you can see, over the last few years, in 2004, up to 4% of youngsters presented coronary artery disease. As you can see, from 2010 onwards, it's almost doubled. These are statistics straight from a journal of cardiology. But I would like to add a personal anecdote. That's because I am working in the emergency department and I've been there for the last 8 years. It's been staggering how I have seen that difference. In my first year when I joined post-graduation in emergency medicine, for me, a typical 50, 60-year-old person coming with chest pain was high probability MI. And the younger ones, I would always say they are very, very low. They may have pericarditis. They may have a pneumothorax. They may have some non-cardiac chest pain. But last few years, I have noticed that change. I have seen at least 8 to 10 youngsters, the youngest being 26 years old, coming with an MI, ST elevation MI. In fact, on one of my shifts, my junior resident told me that he's got an ST elevation MI on a 28-year-old. And I said, there's a mistake. Either you've got the wrong ECG or you've got the wrong patient, or you've got the finding wrong. We repeated it and we were baffled to see that it was an ST elevation MI. And this young patient was taken up for an urgent angioplasty to show a 90% block in the left anterior descending coronary artery. Similarly, we've started seeing young strokes, 25-year-olds, 28-year-olds, 30-year-olds, increasing number over the last few years. So from personal experience, I would say, please take these statistics significant. They are significant statistics. Let's please take them seriously. However, I would hate to just keep on discussing the problem, be a complainer and not discuss solutions. So let's discuss some solutions. First thing, if you're a young medical student, there's only one solution for you. Please sleep. Sleep well, preferably not during your class hours during day. The night is completely yours. You're not expected to do major groundbreaking work during nights. You're expected to sleep, attend your medical school during day. Your evenings are meant to study. Evenings are meant to have some fun. But please reserve the nights for sleeping. Of course, the one odd party is okay, but don't make it a habit. The night is best meant for sleeping. Please sleep. Moving on to the next segment of people who are attending these lectures today. Some of them interns already, some of them residents, but many of you who are likely to become interns and residents in the next few years. Here, sleeping in the night may not necessarily be an option for you. It may just become a luxury sometimes on duties that you're doing for the hospital. In that case, we'll discuss something a bit more in detail for you. Let's first understand sleep physiology. So we've understood that you need 7 to 8 hours of sleep. We have, okay? Sleep debt is an interesting concept. The sleep debt is we all need these 7 to 8 hours of sleep. On a certain day, if you get less than that, say you get 5 hours of sleep, you have a sleep debt of 1 to 2 hours. You need to pay that debt. The next day, pay the debt off by sleeping 1 to 2 hours extra. Now, this is my favorite statistic here. This says that if you haven't slept for 20 to 25 hours, okay, you haven't slept at all, and you come into work the next day, your cognitive level, proven by studies, is that of someone who has a blood alcohol concentration of 0.1%. That is 100 mg per deciliter. Now, I don't know if you all already know, some of you may want to put in the chat box, what is the legal limit for drunken driving in India? Anybody wants to take a guess? Not that you should try your luck with it, but just if anybody knows the numbers. Okay, so the legal limit in India is 30 mg per deciliter, after which you get fined for drunken driving. So what this means is that if you haven't slept for 20 to 25 hours and you come to work the next day, you're literally worse than a drunk person treating patients. So please don't do that. Sleep well before you come to work. Sometimes it's not in your hands, but sometimes it is. So please grab that opportunity, not just for yourself, but also for the well-being of your patients. Let's discuss this. This is probably the meat of today's discussion, the main course, let's say, if some of those vegetarians don't like that. The main course for today's discussion is the first night shift, how you prepare in a series of night shifts. Now, night shifts are becoming more and more common with the advent of proper emergency departments, critical care, and some other broad specialties picking up shift-based work for their resident and intern doctors. So let's understand, how do you prepare for the night shift? First thing, like I already mentioned, get some sleep before coming to the night shift. Okay, like I said, if you haven't slept the whole day before your night shift and you don't sleep in the entire night shift, towards the end of your shift, you are becoming a bit of a drunken hazard for the hospital. How is that done? First thing, sleep late the previous evening of your night shift. Okay, so when you sleep a bit late, you will feel a bit more sleepy during the day. When you sleep during the day, you wake up fresh and you come in for your night shift. Always prepare in advance mentally for the night shift. Most people hate night shifts. To be honest, I've hated night shifts. They are busy, they're chaotic. You don't feel very comfortable working at an unearthly hour. But then there's no point repeating these negatives about night shift to yourself. Talk about the positives. Night shifts are times when you don't have much supervision, which is bad sometimes, but it's good because that's when you build your confidence. And many people have told us from gossips within night shifts that night shifts are the best times for love affairs, friendships to bloom. So tell yourself these things. Look forward to that night shift. Get some good sleep, of course, before the night shift. Okay. Now, looking at surviving the night shift, as you can see, there are 4 stages of sleep. There's something about falling asleep, which takes a few minutes. Then you go into light non-REM sleep, about 20 minutes to 30 minutes. And then you go into deep REM sleep, 30 to 45 minutes. And from that, you enter between 1 to 1.5 hours into the deep REM sleep. Okay. Now we'll discuss the relevance of this on your night shift. Now, question is, should you sleep in the night shift? The ideal answer is no, not at all. But then there are times, sometimes in the night shift, you're just simply exhausted and you can't stay up, or you're just feeling sick. Best thing to do on that night shift is to get what's called the power nap. Okay. Power nap is ideally 20 minutes. Push comes to shove, 30 minutes. When you have this 20 to 30 minutes of power nap, you're still in that falling asleep to light non-REM sleep. You wake up completely refreshed. And this is what is ideal on the night shift. The moment you cross this 20 to 30 minutes, go into 1 hour of sleep, you're going into that deep sleep. And this sleep is dangerous because when you are woken up from this sleep, you wake up groggy and irritable. Again, gossip tells us that these are the periods when most number of arguments and fights have happened, most breakups have happened, most people have held each other's collars because they're just irritable and they don't realize that they're so irritable that they are fighting with their colleagues. Most patients have made complaints about doctors and nurses being rude because you've pushed your sleep too far and gone into NREM sleep. The third category, of course, is you go on to sleep more than 1.5 hours in your night sleep. You enter REM sleep and you wake up, if you do, with perfect satisfaction. Now, this you believe is great, but realistically, it's not. The problem with this deep satisfaction after that REM sleep at night is that when you go back after your night shift, you go home and you want to sleep, you are unable to sleep. This is simply because you've had that satisfaction, you can't sleep during the day. And the problem is if you can't sleep during the day, you're going to wake up, you have to come back to the night shift, you haven't slept during the day, and you're going to have a tough night shift. So yes, you need to tire yourself out during the night shift, okay, and come back fresh for the next night shift by sleeping during the day. Now, during these inactive periods in the night shift, when you don't have too many patients, try not to sleep. The ways to do that is offering your other colleagues some help. This obviously never hurts. Always helping them will come back in a good way, but you'll also learn more. You'll build stronger bonds. And of course, keep the lights on. Just because you have fewer patients or no patients, don't turn the lights off. That will trigger sleep. A quick mention about the night shift eating, although it's not part of today's discussion, just to tell you, try to maintain the normal eating pattern. Have before your night shift, tell yourself this is a breakfast, have a heavy breakfast. I used to do this myself, and have a high protein meal. And then halfway through your night shift, which is somewhere at 2 o'clock, rather 2 a.m., tell yourself this is 2 p.m. It's lunchtime. I used to do this when I was working in UK. I used to tell the nurses, oh, it's 2 p.m. I got to have a lunch. And people thought I was crazy. But what I was doing was maintaining a meaningful eating pattern. So I'll maintain meaningful sleeping pattern. So I had that half medium lunch. And then I finished my night shift at 9 o'clock in the morning. I told myself this is 9 p.m. Murthu, it's dinner time. Eat something light and go to sleep. This is important because if I skip that midway lunch, 2 p.m. rather 2 a.m. at night, two things happen. I go back to my dormitory, and at night, that is rather at 9 a.m. when I'm trying to sleep, I'm so tired that I sleep hungry, or I'm extremely ravenous and I overeat before sleeping. A quick mention of the coffee. Now you may believe what's the big deal? It's a coffee. Why are we discussing coffee? But there are some nuances, and it's important because I started paying attention to these nuances on my night shift. What's PRN? Anybody wants to put in the chat box? It's a bit of the doctor's orders. PRN is pro re nata. It means medication to be taken SOS basis, as and when. Like we write paracetamol, SOS, PRN, take paracetamol as and when. So the coffee is usually done by night shift workers, take it as and when. But it's nice to just put a little thought before you have that coffee. First thing, to understand that the onset of the action of coffee, the kick, is about 20 minutes. Okay, it's not immediate. So you're sipping coffee and feeling awake. It's probably just a placebo. It's not making you awake. It takes about 10 minutes to start metabolizing and about 20 minutes to kick in. Okay, and it lasts for about 3 hours, which then means that if you are planning a power nap, okay, what usually people do is they have a power nap, they wake up and have a coffee and get back to work during night shifts. It actually doesn't make so much sense. Now, what I'm going to tell you, it'll appear a bit counterintuitive, but if you put these facts together, you realize how much sense it makes. So before you plan a power nap, you're feeling really drowsy and you're going to sleep, have a quick coffee and then go to sleep. So in 20-30 minutes, you're going to wake up because the coffee woke you up, and it'll help you achieve your power nap and help you wake up with less pressure and wake up fresher. Okay, so think about this, share it with your friends. Don't take my word for it. Try it out yourself and see how your power nap goes. Okay. One of the important segments of today's discussion, the second half, let's say, of the main course, is the daytime sleep at home. Now, this is really, really challenged. I've struggled for years with this. It's just unnatural. Like sleeping, working at night is unnatural already, and sleeping during daytime at home for 5 or 6 or 8 hours is even more difficult. So I have struggled, and this segment of sleep hygiene, I'd like you all to pay special attention because this is important. Not just if you are doing the night shift, but even if you are a medical student, working, studying during the day and night you're trying to sleep, just remember sleep hygiene tips. First, this is challenging, I understand, for all of us, especially the mobile phone. It's okay to not have a TV or a PC. I don't have a TV, I've not had one for the last 13 years. So that was easy for me, but the mobile is a bit challenging. I try to keep it as far away from me, with at least more than 2 arms distances away from me when I'm trying to sleep at night. So please do consider this. It's really important. The blue screen from the laptop, from the mobile phones is extremely stimulating to the brain. It tells your circadian rhythm in your brain not to sleep. It tells your brain this is day hours, so it doesn't let you sleep. Okay, so keep that in mind. Try to avoid worrying about what happened during the day or what happened during the night shift, and keep your focus on pleasurable thoughts. I sometimes tend to think of my Scotland holiday, which was absolutely fantastic. The moment I think of that, I'm already smiling to myself. Of course, some days I read a novel to sleep. I pick up a light, fun novel, which helps me fall asleep. And if you spend more than 30 minutes in your bed trying to sleep and you're not able to do, then it's time to say it's not happening. No point pressuring yourself to whipping yourself into falling asleep. It's not going to happen. Walk off that room, get a new spot, get yourself a nice hot water bath, do a bit of a hobby, get some fresh air, and again come back after 20-30 minutes to see if you're able to fall asleep now. All right. So these are some tips. Some of them are difficult, easy to speak, difficult to follow. But if you really value your sleep and you value the long-term effects of that sleep, I'm sure you'll start practicing some, if not all of these. Remember to keep your room dimly lit, pull all the curtains, keep the light as a low intensity as possible. With this, you're telling your brain that it's night, sleep. So the brain automatically perceives dim light as sunset and helps us sleep. Right? Similarly, warm water bath sometimes creates a lot of peripheral vasodilation because of warm water. And when there's peripheral vasodilation, there's lesser blood flow to the brain, which sometimes helps in triggering sleep. Of course, good foods which help in inducing sleep through various mechanisms of neurotransmitters is a glass of milk. They say walnuts, bananas. So please keep these healthy foods instead of snacking with random chips, which actually the crispy sound of the chips triggers the brain to become awake. So I would say stick to these healthy foods, at least during your night, so you fall asleep better. Okay, I believe that if you follow at least 50% of these things, and I believe again that if you are able to motivate your friends to do at least 50% of these things, your friends will sleep well, and as a byproduct, you will also be able to be accountable and you will also sleep well. I'd like to quickly summarize with some take-home points. And if anybody wants to type something in, I think I look at this session as not just some information sharing session, because I think there's enough happening on YouTube. There are thousands of people talking about thousands of things. I would really appreciate if this becomes more of a personal commitment session where each of us is willing to make a commitment. Type in the chat box some of the take-home points for yourself. When you do that, you're making a public statement, and that will make you accountable. Or you're making a statement for yourself to revise what we've just discussed, and some of it will percolate into habits. So I'm hoping, I'm not able to see the screen at this point. I believe that lots of you are typing right now, chats to yourself, and some of you are shy to type something on the chat. Don't hesitate to just send a random text, WhatsApp text to your best friend, your partner, your family member, about 2 or 3 things you're going to do from today to make small changes in your sleep patterns. So I'm going to continue with my take-home points. Yes, youngsters are at risk for coronary vascular disease. The risk is real. Somewhere between 7 to 8 hours is the sweet spot for sleeping. Let's not pressure ourselves, but let's keep this number in mind and keep targeting that. Please prepare for the night shift. The night shift is not just going to magically be eventful. And it's not going to be magically smooth. You have to put an effort. The effort is all that we've discussed today and a lot more. Please motivate yourself and each other. And remember, sleep hygiene tips are extremely boring. Some of them are very difficult. But like I said, if you have to take care of yourselves, because ultimately we are healthcare providers, one of our jobs is to take care of vulnerable patients. And you can only do that if you can first learn to take care of yourselves. So please, let's all promise ourselves. I can see some chats coming in, and I can only believe. I can't push you any more than this, because then I'm going to sound like a bit of a nosy, annoying host. I don't want to do that, but I'm only going to believe somewhere in my heart that lots of WhatsApp messages have been exchanged between people. Small commitments made, some comments shared. So that'll give me peace. I'll sleep. I'll sleep well if you all have done that. Looking forward to more interactive discussions from all of you all. Some nice comments to make this journey a bit more fun and more easy. We went on to publish a book. A group of psychiatrists, myself, some emergency doctors. This book is published by Paras Medical Books. This is available online. Please do purchase it. Please have a read. It's light and mostly fun. A quick mention, this is the last segment. We won't take more than 2 minutes for this. How we all can help Code Blue as a company grow. I would believe that Code Blue is not just a company, it's a movement. It doesn't belong to me, it doesn't belong to you, it belongs to everyone. And how we can help this movement grow. First thing, this is free of cost feedback. What you've heard today, what you think about the company, we'd like to hear from you. Please do email us, and some of you who find emailing boring, please feel free to WhatsApp us on this business account. The number is here. Of course, a little bit more effort. I wouldn't mind pausing for a few seconds here for some of you all to open your Instagram accounts. Please find us on Code Blue here on Instagram, and please follow us there. The more numbers we are, the more we're able to exchange ideas. The more visibility we have when we go to people with business pitches. Of course, on Facebook also, please do find us. And as we are speaking, I'm going to believe that some of you are already trying to find us on Instagram and Facebook to follow us. Of course, buying our wellness products. This is a small initiative. We are seeing how we can make a business out of it. All these products are designed by doctors from various parts of India, from various walks of life. Please do buy these products from our WhatsApp number. The catalog is there. And some people have donated resources, money, and sponsored events for us. As you can see, this fantastic guitar has been donated by Dr. Gautam, who's working with Doctors Without Borders, currently in South Sudan. He donated this guitar to Code Blue after he saw what work we did. A fantastic well-wisher and friend, Dr. Deepthi, and her husband from Singapore donated 57,000 rupees for us to make protein energy bars for COVID workers in government and trust-run hospitals. We've distributed good thousands of these already in various hospitals. As you can see here, we've had Dr. Divya Rani, who is a doctor in Mumbai. She volunteered to make these. And of course, the recipe is by our very own Dr. Linda. And here you can see the poster has gone out to many of them to say thank you to everybody. Please do consider attending our events. We are planning a photography event, a poetry event, a picnic in Mumbai. And last but not the least, if none of these is possible at this point in time, please do consider spreading the good Code Blue word. Tell people about us. When we have events, you see our events. If you can't take part in them, please make sure you push your friends and family to take part in our events. That will mean a lot to us. And I don't know if I've exceeded time, but I hope I've exceeded your expectations. It'll be nice to hear from you for the next few minutes. Thank you so much. It's been an absolute pleasure. Thank you. Thank you.
Thank you so much, sir. Always a pleasure to hear you speak and even throw some, shock bombs at us to kind of get us to listen. There's a question that's come in from Viranchi asking, how do you advise good sleep hygiene to someone who's on medication like antidepressants or benzodiazepines? So, your thoughts?
This is fantastic. Thank you so much for asking this question. So there are two deep parts to this. First is just discussing antidepressants and benzodiazepines scientifically, and second, on a larger scale, doctors have to accept that we are also human beings. We also end up with mental health problems. We are also I've been on medication myself. So my therapist helped me a lot. She gave me the same advice. A lot of the things that I've said about sleep hygiene apply to those people who are not on medication, and also the same advice applies to those who are on medication. Of course, you have to be careful. Speak to your therapist. Time your antidepressants and benzodiazepines such that it potentiates your sleep. Some of the antidepressants are stimulant antidepressants. They tend to affect your sleep in some way, and some of them actually augment your sleep. So your therapist will best tell you which antidepressant you're having and how it's affecting your sleep patterns. Based on that, the dosing and the timing may have to be adjusted. Having said that, the deeper issue, of course, is to acknowledge that there's a problem and not feel shy that we are doctors. We are not supposed to talk about these things. In fact, nowadays, doctors who are able to accept that they have issues are probably considered braver and probably considered kinder, because then they are likely to do better and honest patient care. So thank you for asking that question. I would say the answer lies somewhere between your therapist and somewhere between what is already discussed. Thank you, Viranji. I can see a second question there. It says, so just a comment. It says, leverage coffee knowledge for power naps. I'm guessing that's a largely positive comment. Thank you so much. And I'm sure you have to try it out to see whether it works or not for you. And if it doesn't, please feel free to write back to us so we understand this concept better as we keep preaching it to more and more people. I'd love to hear more, one way or the other. So, any closing thoughts from you as one of the organizers? One of the few people I've known who stuck with Code Blue and trying to help us in whichever way you can. Any thoughts that you would like to share? Good, bad, constructive feedback is obviously welcome.
So I think I'm just really glad that Code Blue agreed to be a part of Innovate and, to share this noble mission with all of the attendees at, from St. John's and beyond, because, this is something that we all should care about, should want to be a part of, because it's it's healing the healer. So I think that, taking that forward definitely I'm glad that we were able to offer a platform for that, no matter how many other people we reached.
Thank you so much. I think the numbers usually don't matter as much as the impact, and the impact, I'm sure, is fantastic. It'll keep growing. Thank you so much.
Thank you, sir. Any closing thoughts from anyone else? Okay. With that, we come to the end of an extremely stimulating set of lectures. Thank you so much, sir, and to all of our previous speakers for really brightening up our Sunday evenings. Thank you so much once again for tuning in, and signing off. Thank you.